Good morning. Well, thank you for the lovely introduction, and it's a pleasure to present here today part of our work that we are doing at the Erasmus Medical Center. Let's see. All right. So one of the challenges that we are facing is actually bringing in, our mission statement says that we want to bring omics into the clinic. Okay, that deals with large volumes of data, and if you want to bring omics to the clinic, you should have a vision, and our vision is actually that basically healthcare is changing. It's the coming years, more and more personalized medicine will be the focus, and that's basically enabled by applying omics techniques to stratify patients into different subtypes or subgroups. Well, our strategy to roll out personalized medicine is to go and deviate away from prescribing a blockbuster and basically stratifying patients into subgroups using molecular diagnostic technologies. And for certain subgroups of your patients, targeted treatment is currently available, and for some subgroups, it's not yet discovered or available. So we have lots of translational medicine projects, of which I'm going to show you some examples, where we are trying to discover new molecular mechanisms which are characteristic for those subtypes, on which we can actually apply these personalized healthcare strategies. So we're faced with an expansion of data, and we try to translate the data into information, and what we immediately realize is that there is an incredible gap between your information and your current knowledge. Working in a clinic actually makes you have to do a next step, is actually translating your knowledge into clinical utility, because we're trying to treat patients. So nowadays, and especially these months, it's becoming very actual that we deal very secure with our data of our patients, and that we respect privacy laws, etc. But also, in the past, we already had to obtain, I'm going very fast here. Let's see. We had to obtain medical ethical approvals for all our patient-related research. So also, our clinic is now recently ISO 27001 certified with all its data center, and that's a very unique position at this stage, with the GDPR becoming actual at the end of this month. We recently obtained a Horizon 2020 project in the field of cardiology. It's a collaboration with Philips, the national insurance company Achmea, and TNO, and basically it focuses on cardiovascular heart failure. What we are going to explore is what healthcare costs are connected to treating heart failure patients, and can we optimize the procedures that are currently in clinical practice used to actually treat those subgroups of patients. And one activity that we did is download from the national 94 hospitals all the data in all these medical disciplines, and we zoomed in on what kind of diagnostic activities are focused onto cardiology, and then you'll see that there will be something like 56 diagnostic codes in the space of cardiology. Okay, if you're going to do basket mining and you connect the diagnostic codes with the diagnostic activities, the activities tell something about the diagnostic code which is attached to it, and it of course has a cost price connected to it. Okay, I'm going to talk about genomics in a later stage, but what we were very fascinated about was that we took the data from the Netherlands, heart failure, total cost in the Netherlands, on average 1.2 billion euro for the whole Netherlands. Basket mining, 7 buckets, divide the cheapest diagnostic product in bucket number 1, the most expensive diagnostic product in bucket number 7. We throw around bucket number 7, oh, there's only one product. This one product is actually representing half of the 1.2 billion euro that we spend on heart failures linked to one product. That's something we didn't realize, that there is one product which is actually connected to half of the total cost of the 1.2 billion. And that's why data analysis can guide you to where are spaces of interest for improvement, which immediately generate an impact. That one product, anybody has an idea what is the product? It's a pacemaker, indeed. And we sell 20 different kind of pacemakers, and once the thing is not working, you have a problem, and it's a relative acute problem, so you want to tune the thing, but if you have 20 vendors, maybe it's cheaper to have 10 vendors and to tender the purchase, but also you have less variation if you have to tweak the machine, because optimizing the regulation of the device is very complex, and that's what we can see on the attached activities that are connected to the use of the pacemaker. All right, we are looking at prevention, and we want to use data to think about prevention. And what we know from studying adults and aging adults is when you have suboptimal circulation, you get heart diseases, which actually can result into lesions into the brain, which later on in life actually can cause dementia. So, looking back at those healthcare costs and collecting longitudinal data, we try to find co-morbidities, so co-occurring events, which actually are going to predict what direction are the heart failure patients going. Are they going towards dementia after their first cardiovascular problem? Are they going towards rheumatoid arthritis? Or are they going for a stroke or another cardiovascular incident? So, looking at those healthcare data and at the national claim data in the insurance database of Achmea, you can actually see at the individual base what is the progression during lifetime and what claims have been done by those individuals. Okay, so we defined health. Health is partially composed by your genetic profile right after you're born. Okay, you have some variants, you have to deal with them the rest of your life. Your lifestyle is very important, and of course your environment, which is basically also important in terms of your exposure to less healthy activities, etc. So health has a risk component in the DNA. Sporting a lot, eating enough vegetables, etc., sleeping in a regular pattern. Your behavior can be monitored with modern eHealth devices nowadays, and we try to connect that with our population studies that we have ongoing here in Rotterdam. So there are Rotterdam studies, as like there are the Framingham studies in the United States. So we collect data from pre-womb to tomb. So even before the child is born, we already collect data with our fertility studies here in the Generation R activities. And during lifetime, we collect more and more data, and we try to analyze that. Now I'm going to give you an example in which the Department of Dermatology, Immunology, and Internal Medicine are involved, where we look at longitudinal data. So a mother presents with a child 3 months old. The child has eczema, and basically they look at the child in children's hospital, gets a cream, the eczema goes away, and then the mother returns with the child at age 15. The mother doesn't realize that she was with a child 15 years earlier in the same hospital for a related event. But what we know is that eczema and asthma and hay fever are very tightly co-occurring comorbidities. So we looked up all the genes that could cause eczema, and then we started which of those genes have actually occurred in the context of asthma. And now we start to see very clear pattern. If you just take normal blood and you look in the profiles of all the different blood cells, they all have their own specific barcodes, then actually the genes that are mutated in the context of eczema, they have very specific distributions in the different blood cells. But you can actually see that in the different lineages in which the measurements have been done, you get a barcode. And actually, if you have 800 different experiments, we are seeing that some patients actually have exactly opposite barcode in 800 measurements. And if they are completely opposite, the chance if you go to the casino and you put either on red or on black, and you do that 800 times, and it is exactly in the same order, that chance is very, very small. That I don't succeed, so I never win money in a casino. So that made me think, maybe I'm seeing something what I can push with an agonist to the left, and what I can push with an antagonist to the right. And actually we started looking into those pathways, and that's our new ways of stratifying patients, because if you want to test a new drug, you just enroll patients, and you have no clue in general who to enroll. But if you upfront can see what's the barcode of that gene in which is a mutation in normal blood, and you make that group with the genes and the other genes which are in the other cluster, which actually have an opposite behavior, then you start to test the drug in the two groups, but you analyze the group separately. And that's the new type of approaches in which we apply a test to study the genome, general test for cancer, cardio, neuro, immune, transplantation, and pediatrics. You classify your data, you interpret, that's all category laboratory, you publish, you shout around, we found this, we see this, and in some cases it leads to an intervention, an action in the clinic now. And more, by keeping using this same pipe, your knowledge archive is getting enriched, and it becomes more and more efficient to reuse your data. Another trend that we see is that basically imaging data is approaching the molecular data, and the molecular data is approaching towards the imaging data. So we label more and more biomarkers, which we discovered with our genomics or proteomics technologies, and we want to visualize them in the PET-CT or in the MRI with labels, etc., in order to basically diagnose way more efficiently and use biomarkers from the genetic studies. And I'm going to give you one example of what we see in development in pediatrics, which actually relates directly to what we see in the cancer space. So certain mutations in children are involved in craniofacial disorders. So you see a child which has a premature fused skull, and in between, so in the sutures, there are stem cells, and those stem cells are neural crest-derived stem cells. And if you have on one allele a mutation, you get those craniofacial disorders. Okay, here we have basically found a mutation in MSX2, and this is the patient, and this is actually an embryo. And in the embryo, we can label the MSX2 protein, and we stain it in embryonal day 11.5. And we know that we picked up the mutation in the patient because of a suture problem. Now, I'm going to start the two movies, and if you look very careful, you see on the mouse skull, the suture is lighting up, sagittal suture. And basically those neural crest stem cells, they can differentiate into neurons, glia cells, melanocytes, craniofacial bones, and teeth. That's very interesting. So if you look at those patients who have craniofacial disorders, often they have also very lousy teeth. Unfortunately, in the Netherlands, the information, your dental records are not in your healthcare record. Very stupid, very stupid. So, looking at those stem cells, realizing that your craniofacial bones also develop from the same stem cell, actually, if you look very careful, you see the upper jaw and the lower jaw development very clearly lighting up. And the development of the limbs. Okay, what's happening during development? Lots of cells are dividing, and lots of cells are dying off or getting into a rest phase. That's why these fold changes in a developing phase are occurring, because not everything is dividing at the same time. It's highly regulated by the genome. Now, one thing that we realized by looking at those limbs is that you get apoptosis, which separates your fingers. So those stem cells are very important in understanding in the context of cancer. If you want to drive something towards apoptosis, you want to very likely do something with that pathway which drives something towards cell death. So we use development as an example for studying cancer. Now, why did I start sequencing whole genome 300 patients who have craniofacial disorders? That didn't come out of the blue, because I had an interesting idea, which is coming from the following knowledge mining. So, first I'm going to explain, you know what you know, that's why you read your literature. You know what you don't know, that's why you do a diagnostic test. Now I'm going to make it very exciting. You don't know what you know. Usually that information is in your drawer. And in order to get the doctor very scared in the clinic, you say, you don't know what you don't know. Now this you actually can calculate. So here you see, over time, from week 3, human brain in utero till birth, so week 37, week 1, age 40. Same brain regions. Okay. The most striking difference is at that blue line. And you know what's happening there? You cut the umbilical cord, and the amount of oxygen which is flowing through your body is changed. That silences a whole part of your genome, and that's actually what you can see by those genes which are here switched on and which after birth are switched off. That's very interesting, because those genes you also see back in the context of cancer. But people don't realize, so they don't use this information in an efficient manner to look at their cancer data. So reuse of data in a repository creates an incredible amount of value to get total new concepts of how to look at your information. If you take those numeric values here and you do a Pearson correlation on it, you suddenly get processes, because the samples that you see over here are here samples versus samples, and this is just a Pearson correlation of the same data. So there is 1, 2, 3, 4 processes very clearly driving this development over time. Very interesting. So with Ken, we already did many years ago a lot of work on acute myeloid leukemia to stratify patients into subgroups. So we looked at the same transcriptomes, at all those genes, where are they expressed, and this is focusing on blood cancer. And we published in the New England Journal of Medicine a stratification of acute myeloid leukemia. We could very clearly recognize a particular subtype, which is basically comprising 15, 17 translocation patients, and those you can treat, for instance, with a drug which costs €12 at the pharmacy, where the other patients would actually need to get a bone marrow transplant. Once you build a diagnostic device in which you put the probe pairs to actually measure those genes, you can stratify the patients very clearly into those subgroups, and we had 300 patients, and out of the 300 patients, 4 in the category of the 15, 17 would actually, by conventional looking through the microscope at the morphology, be classified in another subtype. So 4 times you do a bone marrow transplant cost €150,000. 4 times that budget gives you a lot of space to develop a diagnostic device. So that was our business case roughly behind the development of this stratification tool. We started repeating this in many different areas, making use sometimes of expression data, sometimes of protein markers that we measure in serum in our patients, sometimes looking at small molecules from our clinical chemistry laboratories, and of course we connect everything to literature of patents and of course the public domain literature. Now 4% of our healthcare cost is roughly spent on diagnostics. 72% of what we decide in the clinic is based on the 4%. So I went to the minister and I asked, can I have the 1.1% more next year and just give it to me? I'll show you something with my genetic programs where for $1,000 I can sequence the whole genome. The minister was looking and said, well, you don't get the 0.1%. Keep playing. This is too far off from reality now. And then she decided to travel with me to California because we had hired an apartment next to Stanford University. We were shipping every week boxes with samples. And we said, you don't want to pay? Great. Talk to you later. So we started teasing her, and I'm going to show you why. Okay, different components you want to use. We see an increase from the current situation towards a new situation where you do more diagnostics and you're going to treat less. So that's a clear paradigm shift. Okay, what we are now doing is sequencing all the primary immunodeficiency patients, and okay, you see different colors in this circle. The oncology is this dark blue pie, less than a quarter. This blue part in the bottom, the largest part, is actually infectious diseases. And those are very interesting in the relation towards the primary immunodeficiencies who have a total big problem with their immune system. To give you an idea, how many children have a severe primary immunodeficiency? It's 220 new patients on average per year in the Netherlands. 70 million people living in Holland, 220 new patients. 8 hospitals competing for those 220 patients. Okay, then we thought, stupid, let's go towards Southeast Asia. 130,000 primary immunodeficiency patients, 760 million people living there. So, we have now developed a diagnostic chip on which we have put all the known mutations, and we are screening in a chip which costs $25 all those patients, and you solve 80% because it's known mutations. So everything what's not known is not on the array, you can't pick it up. Everything what's known, you test suddenly for $25. Here you do a whole genome, which costs €1,500. People in Southeast Asia can't afford €1,500, but can afford. So by looking for the volume, we can reduce the price. So this is what we are now seeing as new opportunities, and that's why basically we see the increase in the growth of the molecular diagnostic testing market, and actually all those developments, they start innovative research in universities. So making clever devices is actually making sense. Now here you see all the diseases. They're connected with genes, and what was very obvious to me that all these blue balls reflect cancer. And there are certain genes which connect all the cancers. What was striking to me that behind those blue balls there were a couple of pink balls. And those diseases actually reflect mutations in MSX2, fibroblast growth factor 1, fibroblast growth factor 2, and fibroblast growth factor 3. Now those diseases, Munke, all those, they're characterized by craniosynostosis, and that's the premature fusion of the sutures of the brain. So are those craniofacial patients, if you look at big data, is this a concept, these pink balls, are they having something in common with what's going on in cancer? In cancer you have a lot of chromosome instability, very difficult to study. If you have inherited syndromes like those pink balls, you have stable genomes and you can study much better what's the underlying problem. So that's why I started sequencing 300 craniofacial disorders. We found mutations, and what's very striking, those red diseases, Crouzon, Munke, all reflect receptors that are also mutated in cancer. Bladder cancer, FGFR3. So now suddenly I have a congenital model for complex diseases and mutations that occur in cancer, and actually those downstream pathways are very, very characteristically described already for what's going on in our transcription programs in cancer. So, focusing back on cancer gets overruled by the immune system. You eliminate your tumor cell. Once the immune system is equally as good as the developing cancer, you get an equilibrium. And here you get the bad situation that your immune system can't control the tumor anymore. That's why a lot of immunotherapy is developed now. And once your cytokine regulation is disrupted, your tumors are going haywire and all over the place, and you get metastasis. So those are concepts that we start to use in immunotherapy nowadays. So we're looking at how can we efficiently use our data. So half of your DNA gets from your father, the other half from your mother. Human length is genetically determined, and we're comparing genomes as bikes. And if your bucket up in front of your bike is upside down, you can't bring your bag. So that's a non-functional change in your genome. So that's the efficient way of exploring. So this is more or less genetics for dummies. Over here, we have 8.3 million homozygous mutations. So as a geneticist, I'm just looking at 250 kilometers of paper, and I'm stacking all those genomes on top of each other, and I'm filtering. And I'm just looking for changes that are characteristic for my subgroups of my well-defined patients in cancer and congenital disorders. We have loss of function mutations, gain of function mutations. Those have very different clinical presentations. And because of the speed, I'm going to continue again the parallels with the teeth. The STAT3 mutations, gain and loss of function. STAT3 is very important in the immune system. So in different subtypes of the cells, but what you see here is that once you have in STAT3 gain of function, you get type 1 diabetes, autoimmune diseases, but over here, the loss of functions develop facial dysmorphism, they get cardiovascular problems, they have hyper-IgE, they get dental abnormalities. So you see many, many patterns with those mutations. So clinical presentation is very important. We also look at these gender biases with those immune pathways. And then we realized that there is a whole spectrum of patients being seen by our internal medicine doctors, where you see here all the diseases, but they range from autoimmune towards autoinflammatory response. So those immune pathways, you want to understand very clearly what's going on, and that's why we now actually are sequencing all those patients at a molecular level and stratifying them much more efficient than we did in the past. So we tease the minister because we say, we claim this money for all these separate diagnostic tests. Or should we sequence the genome, the ultimate genetic test, do the whole genome at birth? No, not the $1,000 genome. No, we can't do this. Ethically not okay. Great. Then we keep claiming these costs, and we're doing in practice this. That's what you want? Success, bye minister. Oh, spec, not allowed. Very interesting. So we keep teaching our young doctors, we keep discussing about reimbursement, and of course your legislation and regulation needs to be in place. But it's a very dynamic area, and I have given you some overview of what's going on in healthcare when combining molecular and new image-based information of your patients. That gives the new opportunities for disease management. And last but not least, the patient himself is asking, what does that mean for me? What's my prognosis once they have diagnosed cancer in those individuals? So here we see some acknowledgements to the Southeast Asia activities that we have mentioned in the immune space with the patient organization IPOPI. And actually with this, I would like to close my session and open the floor for questions. Thank you. Yes.
Obviously, your research can have impact, but I was wondering how easily you manage to collaborate, let's say, with the clinical side and have this new knowledge applied, because I know that these are not clinical guidelines, but you.
Of course, it's research, what you want to bring to the clinic. But in order to get the doctor with me, that he is going to share the data, I need to have a carrot. If I have a carrot, innovative technology, they like it. They're going to share their stuff with me. So what did I do? I'm going to give you one example. Here you see a military slide. The Apache helicopter you had in the screen in 2003. I came back from Johnson & Johnson industry, back at this university. And I used the helmet of the Apache helicopter. And I made from a military patent a healthcare application. And here you see a ham. And here you see in the ham the bone. So if you use the goggles that were in the helicopter when going above a city and you see a roof, and that's where the rocket has to go in. My parallel that I saw with the clinic is the surgeon who is standing here and who has scanned the patient yesterday, and now he's going to do surgery. So he's moving. like the helicopter relative to the roof, is the doctor moving relative to the tumor that he has to excise. Innovative technology, how are we going to apply that? So I built a 3D cinema. I went to the mayor, I said, $500,000 please. He was laughing. He said, get from a company also $500,000. 2 weeks later, I phoned him. I had $500,000 and I built a cinema. And now on the left, we see projection in 3D of MRI, 3D of breast cancer. We see unborn children, and we can do virtual reality, 3D measurements. If we see something suspicious, we can do much earlier genetic testing than before. So you take the innovation, and how am I challenging my institute and the minister? With this, if I now buy a car, I go to the car dealer, and basically they take my cell phone and they plug it in a device on your head, and for €200 you can see your new car in 3D. So why don't we take this technology in the medical center? Because I can port the same data in that Samsung phone, and then I can see my patient in 3D at the car dealer. But that's not what we do. We keep paying the $500,000 in healthcare because it's a healthcare solution. That's life. That's not good. But that's why guys like you and people like you should push the system, show new activities, and ask very smart questions based on the data that you collect. But I really want to do a strong plea for collecting data like you have done in your projects and reuse the data. Over time, you're going to see more and more in your data that you have collected. So don't stop your project when it ends. The fun is when reusing your data. So I'm looking forward to this very exciting 2 days here. And with this, one more question? Okay.
If possible.
Yes.
Of course, we realize that genes and mutations are very important for normal metabolism and disease. But what about epigenetics? What do you think about that? And what is your idea? How can you use it in your...
Very good point. So basically what we do, we have sequenced DNA, we have looked at RNA, we have looked at copy number, we have looked at methylation of the genome. So epigenetics, the methylation, is highly regulated. There is over 30 different genes doing all kinds of different methylations in different cell types. So it's very dependent on what part of the body you are studying and which methylation enzymes are active there. And also lifestyle. We know that methylation can be severely influenced by smoking. So that's very important in the context, again, of the cancer treatment. And basically, when talking to the oncologist, the observations that are being done is that patients who smoke incredibly much, they respond much better on immunotherapy. And that's because of the tumor burden. So you get way more mutations all over the place, and you pump up the immune system, and you kill those tumor cells much more efficient when giving the immunotherapy. So people who smoke respond better. So that's a very, very weird observation, but people who smoke respond better on their immunotherapy when they have developed their cancer. So that's something what you have to be very careful with positioning, that people don't start smoking, because then your immunotherapy later works better. But it's a very weird observation that we did recently. Yeah. Well, when you have your cancer, you can consider maybe, but it's very bad. It's bad. The correlation of smoking and developing cancer in lung is incredibly strong. But the people who receive now with nivolumab their immunotherapies, in those trials we see that the smokers do better than the non-smokers. Yeah. All right, more questions? Yes?
Hi. I think one of the issues for big data for me is this thing of observing a correlation. So, for example, the smoking cancer, we need to go a bit deeper sometimes. I mean, there's lots of areas where correlation is fine, marketing and that, but we need to go a little bit deeper, I think, in medicine to
correlation is not enough to bring it into the clinic. That's very scary. So that's a fair point already raised before. It's research-based, it's not yet clinical practice, but when you want to bring it into clinical practice, you want to collect multiple layers. So like the man says, methylation, how does it contribute to the epigenetics? Okay, so what we don't know at this stage is you have your mutations at your DNA, your RNA level, your protein measurements, all those parameters, they do not all weigh equally. So when doing a correlation measurement, you need to also take into account how heavy does a certain parameter contribute. And that knowledge is still, we are very far off from understanding that, to my opinion. Yeah.
I think on this happy note,
thank you.